Hello students, welcome to this edition of ENT INI-CET PYQs. I am Dr. Ajay Bhandarkar, your ENT SME. So what we are going to do in this session is we are going to highlight a few important topics that have come across in INI-CET, and we will deal with one of the most important topics as far as INI-CET is concerned. So what is the flow of this particular session going to be? So we are going to discuss a few high yield topics, or what are the high yield topics that you come across in INI-CET. We will discuss a few PYQs, approximately 25 PYQs in this session, and then I will discuss a few images which might be useful to you in the coming INI-CET. So to begin with, let's discuss the high yield topics in the year. So if we look at the last 5 years of INI-CET, year has been the most commonly asked topic. So when I looked into it, there are approximately 25 out of 57 multiple choice questions that have been asked in INI-CET that are from the year. So when you take year into account, the most common topic is hearing assessment, hearing loss, and rehabilitation. We will discuss more about this in the PYQs that we are going to discuss, right? So hearing assessment is something, and hearing loss and rehabilitation are the three most important topics. The other important topics that have been asked, maybe in other MCQ sessions like NEET or FMGE, are external ear disorders along with otalgia, of which referred otalgia has been the most commonly asked question. Hello everyone, I can see Dr. Devik and Wonder Gap. Hello. Right. So apart from that, complications of otitis media, one or two questions have been asked in INI-CET. Otosclerosis and vestibular system are the second most important topics, or they are loved by the examiners. You can say that otosclerosis, and when we talk about vestibular system, how you go about diagnosing a particular vestibular disorder, how you go about investigating a particular disorder, and how about treating a particular vestibular disorder is something that we will discuss in a little detail if possible in this particular session. A few questions on anatomy of the year has been asked, including physiology as well. When you look at physiology, most commonly asked question is the auditory pathway. So that is what will come across. So I have taken that into account in hearing assessment, hearing loss, and rehabilitation as well. So let's look at the second important part, nose and paranasal sinuses. Of late, the most important questions as far as nose and paranasal sinuses are concerned are anatomy and radiology of the paranasal sinuses. So when you talk about the paranasal sinuses, lateral nasal wall, its anatomy. Then we do have the various cells in radiology. The commonly asked questions were related to agar nasi, Onodi cell. These were the two important ones that were asked. Okay. Apart from that, there is one more cell, that is Haller cell, that has been asked. So these are a few important questions as far as anatomy and radiology of the paranasal sinuses were concerned. Other important questions that have been asked are related to complications of sinusitis. When we talk about complications of sinusitis, most often the questions will be on orbital complications of sinusitis. Granulomatous disorders are always a favorite. When you talk about granulomatous disorders, there are four important disorders that you need to know. One is tuberculosis. Number two is rhinoscleroma. Number three is rhinosporidiosis. And number four is vaginous. So these are the four important topics as far as nose and paranasal sinuses is concerned. And when we talk about fungal sinusitis, the most or the recent question that has been asked is related to allergic fungal sinusitis, that is the Bent and Kuhn criteria. So you can expect few more questions on fungal sinusitis, like a fungus ball. It can be mucormycosis. It forms a part of granulomatous diseases as well. And apart from that, you can also get questions related to invasive fungal sinusitis and non-invasive fungal sinusitis as well. Right. So coming to the next important high yield, when we talk about larynx, the loud questions are foreign bodies of the airway, the different maneuvers, for example, Heimlich's maneuver, one of the important asked questions. How do you do a bronchoscopy? Few instruments of bronchoscopy. These can be asked as important questions. Tumors of the larynx, supraglottis, glottis, subglottis. When you talk about tumors, once again, stridor and tracheostomy also plays a central role. When you talk about stridor, you divide it into inspiratory, expiratory, and biphasic stridor. So, when you talk about questions on stridor, it becomes very easy to differentiate what is the level of involvement of the airway as far as stridor is concerned. So you look for these key words in the questions. You'll see that when we are discussing otology topics as well, we will be discussing keywords in the question. Sometimes the questions can be answered without the image, just by looking at the keywords in the question. That is what you need to look for when you read a particular question. The other important topic in larynx has been acute infections of the larynx, acute laryngotracheobronchitis, acute epiglottitis. Stick to these two. Most of the questions are related to that. And one question that has not come across, that I have not come across in INI-CET, is vocal cord paralysis. So this has been repeatedly asked in NEET as well as in FMG, but not so commonly asked in INI-CET. So you may expect something new as far as vocal cord paralysis is concerned. Oral cavity, pharynx and esophagus. When you look at oral cavity, pharynx and esophagus, adenoids, tonsils form two of the most important topics. Apart from that, you have disorders of the esophagus. When you talk about diseases of the esophagus, you have achalasia cardia and Plummer-Vinson syndrome. These are the two important topics that you'll come across in most of the questions of yesteryears. Foreign bodies of the esophagus, radiological image can be given to you. How would you remove this foreign body? Where is the foreign body? These type of questions can be asked. One question that has been asked is related to the type of foreign body. For example, a button battery has been asked as a radiological question as far as INI-CET is concerned. So you need to differentiate between a button battery and a circular foreign body, most commonly a coin. A coin will usually be circular, whereas a button battery will have a double ring appearance. So remember, when you look at the radiology as well, look for this particular image properly so that you're able to visualize this. As far as other general topics are concerned, instruments and radiology are now coming up. And then you have neck swellings and deep neck space infections, not so commonly asked in INI-CET, but definitely asked in NEET as well as FMG. But you can expect these questions to come in the future as well. Remember, the trend in ENT is becoming more and more clinical. So you need to understand that questions will go towards that context. It will not be a straightforward question. You will have to read the question well. You will have to decipher the symptoms and signs. And in some cases, you may have radiological images, instruments, or audiological images. And in otology, if I were to talk about, you may also have various tests, and how you interpret those tests, that becomes extremely important when you deal with this. So now let's start with the first multiple choice question. Okay, this was asked in November 2023. Now, if you look at this multiple choice questions, what do you see? You see a patient who presents to you with episodic vertigo. Remember, this is the first important keyword, which is sudden in onset, and it occurs with tinnitus and sensory neural hearing loss. Now, what is important here? You look at the episode of vertigo. It lasts between 1 hour to 6 hours, right? Most important key here is 1 hour to 6 hours. They were accompanied by nausea, vomiting and vagal symptoms. So more often you see a few autonomic symptoms associated with this particular disorder. You see an audiogram that is presented in the image. You see this? This is the audiogram presented in the image. What is the most likely diagnosis? Yes, Rahul, you're absolutely correct. Meniere's disease is the correct diagnosis in this case. But do you know how you can rule out other diagnosis? Yes, this would have been a straightforward answer as far as the keyword is concerned here, 1 hour to 6 hours. That takes away most of the diagnosis. So now let's come into the various options that are in there. So my job is to go through the options. I'm dealing only with otology questions here. That is 25 otology questions that have been asked in the last 5 years, and we'll try to reflect on the different options that have been given. That is what is important. Right. So when you talk about Meniere's disease, what are you looking at? It is also known as endolymphatic hydrops, right? So it is also known as endolymphatic hydrops. So what happens in this particular scenario? There is accumulation of endolymph. So you remember the word endolymphatic hydrops. So hydrops of the endolymph. There is accumulation of the endolymph either due to increased production or decreased absorption. So when this happens, what happens? It's a closed cavity right there, right? So the Reissner's membrane tries to bulge. So it ends up bulging quite a lot, producing the first symptom, that is tinnitus. So what happens when the tinnitus ruptures? It bursts out like a balloon. So when it bursts out like a balloon, what happens? There is mixture of perilymph along with endolymph. When there is mixture, you get the two important symptoms, that is sensory neural hearing loss and vertigo. So this is one episode of Meniere's disease. So what happens over a period of time? The Reissner's membrane heals by fibrosis, and this leads to improvement in hearing, improvement, or the vertigo itself goes down. So remember, these attacks happen every now and then. So when these attacks happen every now and then, the sensory neural hearing loss aggravates. So it starts off with what you see in this image, that is a low frequency hearing loss, because that is the area, that's the apex, which is getting affected first, and then eventually the base gets affected. So a low frequency hearing loss is what you see in case of a Meniere's disease. We'll discuss a little more about it, and then eventually it sort of produces a severe hearing loss over a period of time. Now let's come to the second important option here. There is vestibular neuronitis. Although this is not the answer, you need to know something about vestibular neuronitis. Remember, any of these options, they can enumerate questions in the next INI-CET. So when you talk about vestibular neuronitis, can someone tell me what is the causative factor here? What causes vestibular neuronitis? Anybody? So there is reactivation of herpes simplex virus. Okay. So if you look at vestibular neuronitis, fever, upper respiratory tract infection, then the patient comes to you with severe vertigo, which lasts for more than a day. That is vestibular neuronitis. So there is reactivation of HSV in the vestibular ganglion. So you remember, you have two important nerves there, that is the superior vestibular nerve and the inferior vestibular nerve. So when you talk about the superior vestibular nerve, what does it supply? And inferior vestibular nerve, what does it supply? So can anybody answer that? So when you talk about inferior vestibular nerve, it supplies the saccule and what else? Posterior semicircular canal. When you talk about the superior vestibular nerve, it supplies the utricle, the superior semicircular canal, and the lateral semicircular canal. So this is how you should be able to gauge what are the symptoms, right? Although the superior vestibular nerve and inferior vestibular nerve may be involved, by investigating these particular areas, for example, in a few disorders, for example, disorders involving the utricle alone, for disorders involving the saccule alone, there is an investigation which is called as VEMP, which is vestibular evoked myogenic potential. So this investigation tests these two important areas. So you have the cervical VEMP, which tests the inferior vestibular nerve component, and the ocular VEMP, which tests the superior vestibular nerve component. Right? So let's come back. So I got drifted away to VEMP, but let's come back to vestibular neuronitis. So how does it present to you? Will there be hearing loss in vestibular neuronitis? Anybody in the audience who can tell me, will there be a hearing loss in vestibular neuronitis? Okay, let me tell you, there will not be hearing loss in vestibular neuronitis. It is inflammation of the vestibular nerve. So there is no hearing loss in vestibular neuronitis. They only present with vertigo. Right. Now let's come to the third option. You're looking at benign paroxysmal positional vertigo. So this itself takes away that diagnosis. You see, 1 hour to 6 hours. Most of your diagnosis is made by this, right? So benign paroxysmal positional vertigo is dependent on the otolithic organs. There are calcium otoliths or calcium based otoliths that are present in the utricle, on top of the utricle, or the sensory organ, that is the macula of the utricle, macula of the saccule. So these otoliths, they tend to get dislodged. It can be spontaneous, it can be because of trauma. They get dislodged most commonly into the posterior semicircular canal, second commonly into the lateral semicircular canal, and at last the rare one is the superior semicircular canal. So remember, in that order it is affected, right? So when you talk about benign paroxysmal positional vertigo, it is episodic. It is based on the movement of the head. When you move the head, the otoliths move in the semicircular canal and you tend to get a vertigo spell, right? We'll talk a little bit more about that. There is MCQ based on BPPV as well. Now let's come to vestibular schwannoma or acoustic neuroma. This will help you. So when you talk about vestibular schwannoma, you will have once again episodic spells. That is, it may last for a few minutes to a few hours as well, or it can last for days at times. And along with that, there'll be compressional symptoms. And when you look at the audiogram, it most often starts with a high frequency hearing loss. It will not be a low frequency hearing loss like in case of Meniere's disease. It will be a high frequency hearing loss in case of a vestibular schwannoma. Right. So a little bit more to discuss about this. This one slide should give you the diagnosis. So when you talk about vertigo lasting a few seconds, you have perilymphatic fistula. Very small perilymphatic fistula will produce vertigo for a few seconds. The second important diagnosis when you talk about seconds will be BPPV. When you talk about a few minutes, Meniere's disease comes into the picture. And the other important differential that you can think of if it's minutes is a transient ischemic attack. There is one central cause that can produce vertigo for a few minutes. And when you talk about hours, you have Meniere's disease, and you also have migraine related vertigo. So you're looking at migraine related vertigo and Meniere's disease as two most important differential diagnoses when you talk about lasting for a few hours. And remember, when you talk about migraine related vertigo, they will have the classical symptoms of migraine, that is unilateral headache associated with photophobia, phonophobia, nausea, vomiting, classical. And when you talk about a few days, two important causes in the year, that is labyrinthitis, and you can have vestibular neuronitis. Along with this, one other important is all the way around is central causes. So you have central causes which will cause vertigo for days together, right? So this more or less sums up what you see in the diagnosis. So once again, focus on that key point here, 1 hour to 6 hours. If you're not able to get the diagnosis with 1 hour to 6 hours, then you go to the symptoms and along with that the audiogram as well. So that will give you the diagnosis. So other important associated symptoms that you can have are otological symptoms. So when you talk about the otological symptoms, whenever there are otological symptoms, think in terms of a otological cause. Whenever there are visual symptoms, think in terms of a visual cause of vertigo. When you have motor or sensory disturbances and loss of consciousness, think of central causes. And when there is a fall, there are three important ways by which a patient who is falling due to vertigo can present. He falls and he gets up immediately, BPPV. He falls and there has to be some degree of assistance to help him get up. Think of a transient ischemic attack. Falls and does not get up. Think of a serious cause of or a serious central cause of vertigo. So three important ways by which a fall can also be diagnosed. So that is in differentiation to what MCQ you were seeing. So talking about Meniere's disease, this is the diagnostic criteria. Just a few words on that. You have certain Meniere's disease and probable Meniere's disease. Remember, if you look at certain and probable, the only difference here there would be a low to mid frequency hearing loss. This has been eliminated. A patient presents to you for the first time, you will not diagnose Meniere's straight away. So certain Meniere's disease, this has been proposed by the Barony Society, and definite and probable Meniere's are the two ways by which they have classified. And you need to have at least 2 attacks of vertigo lasting 20 minutes to 24 hours. Remember, the butt stops at 24 hours. So you don't go beyond 24 hours more or less in cases of Meniere's disease. They will have fluctuating oral symptoms. They will have fluctuating hearing loss, fluctuating tinnitus. Vertigo will be present. So fluctuating oral symptoms are a classical feature of Meniere's disease, and definitely you have to rule out other causes. So when you talk about diagnosis or diagnostic investigations in case of Meniere's disease, you have glycerol dehydration test. Remember, glycerol is a hygroscopic agent. You do a preliminary audiogram. Once you do an audiogram, give glycerol in the dose of 1.5 ml per kg. Okay, remember glycerol is very bad to taste, so you have to mix it with lime. Okay, and this is given to the patient, and then you repeat the audiogram after 1 hour or 2 hours, 1 hour and 2 hours rather, and you will find improvement in the hearing. That is because of the hygroscopic nature of glycerol. The second important investigation in Meniere's disease is an electrocochleogram. Right, normal SP-AP ratio, that is the summating potential to the action potential ratio, should be around 30%. If you are looking at a higher SP-AP ratio, that is it increases to more than, sorry about that, if it increases to more than 30%, think in terms of a Meniere's disease. Right, not diagnostic, but definitely an adjunct to diagnosis. When you talk about Meniere's disease, it's more or less a clinical diagnosis, and then all these adjunctive investigations come into the picture. Right, gadolinium enhanced MRI, you look at the endolymphatic space, you look at the vestibule. The endolymphatic space should not exceed 33% to that of the vestibule. So 3 important investigations as far as Meniere's disease is concerned. Now let's come to the second multiple choice question. What do you see here? You have a patient who presents to the outpatient department with complaints of bilateral hearing loss, okay, which is worse in the right ear, right? After examination, the doctor recommended stepidotomy in the right ear. So which of the following would determine surgery on the right side as per the tuning fork tests? So you have 4 options here: right Renes positive along with Weber's lateralized to either side, and right Renes negative with Weber's lateralized to either side. So what would you think of in this case? The diagnosis is basically straightforward. You're looking at otosclerosis because stepidotomy has already been mentioned, right? So what would you be looking at? You are looking at what is the degree of conductive hearing loss, right? So you need to look at conductive hearing loss as the main component here because the diagnosis is Meniere's disease, otosclerosis. So when you're looking at conductive hearing loss, you need to look at the component that is the worse hearing ear, right? So the worse hearing ear is also always operated first in a otosclerosis, right? Remember, we are looking mainly at stapedial otosclerosis. So if we have a cochlear otosclerosis, then the patient will have a sensorineural hearing loss, right? This doctor here has suggested stepidotomy on the right side. So you are looking mainly at a right Rinne negative. Okay, so bone conduction better than air conduction. So this is what you are looking at. And what happens to the Webers when there's a conductive hearing loss? It should be towards the side of the lesion, right? So Webers will be lateralized to the affected side. So in this case, the right ear is more affected. So you have Weber's lateralized to the right side. So this should be the answer. That is right Rinne is negative and Weber's lateralized to the right should be the answer in this case. Right. Before going into key points of otosclerosis, let's discuss a little bit about tuning fork tests. So when you talk about tuning fork tests, we know that there are three important tuning fork tests, that is Rinne's, Weber's, and absolute bone conduction. A few key points about these three tests. So when you talk about Rinne's test, let me just get that a little lower down because it's not visualized on screen. Right, there are two important methods here. You have the threshold comparison method, and the other important method is the loudness comparison method, right? So two important methods as far as Rinne's test is concerned. So when you talk about threshold comparison method, the tuning fork is struck, it is kept behind on the mastoid. Once the patient stops hearing, you keep it in front of the external auditory canal, right? So the difference between the air and bone conduction should be approximately 15 to 20 decibel for you to get a positive response for this particular tuning fork test. So when is Rinne's positive? Whenever the ear is normal or whenever the patient has got a sensorineural hearing loss, right? So that is about threshold comparison method. When you talk about loudness comparison, you alternate between the bone conduction and air conduction. Try to find out which one is better than the other. That will give you a more or less easier way of finding out which one is better. So that is about Rinne's test. There is one important entity which is called as false negative Rinne's test, which is commonly seen if there is a severe sensorineural hearing loss on the affected side, right? It gives you a false impression, right? So the bone conduction gets transmitted to the opposite side and gives you a false negative Rinne's test, right? So that entity can be asked, and it has been asked as one of the questions in INI-CET. So when you talk about Weber's test, you're looking at lateralization. In sensorineural hearing loss, the Weber's test is lateralized to the opposite side or the normal side. When you talk about conductive hearing loss, it is lateralized to the affected side. So what should be the interaural difference for Weber's to be lateralized to one side? You're looking at approximately 5 to 8 decibels. So Weber's test will be lateralized only if there's a difference of 5 to 8 decibels. So it's very, very sensitive test as far as hearing loss is concerned. Sometimes or more often, we say the tuning fork tests are better than the pure tone audiometry. When you talk about absolute bone conduction test, you're testing absolute bone conduction. Absolute means you occlude the external auditory canal. Schwabach's test is you keep the external auditory canal open, right? So when you talk about absolute bone conduction test, it basically tests the degree of sensorineural hearing loss. That is what you will see. Rinne's test has to be done for three frequencies: 256, 512, 1024. It can also be done for 128 and 2048. Whereas Weber's and absolute bone conduction test should be done with a 512 hertz tuning fork, right? So when you talk about otosclerosis, it presents to you with hearing loss. You have paraquisis villi, that is hearing better in loud environments. Then you have Schwartz sign. I've just put the key points here so that you remember what happens in otosclerosis, and you'll be able to help. It'll help you in diagnosis when a question is asked to you. What is Schwartz sign? Schwartz sign is a reddish hue or a flamingo pink appearance that can occur in active otospongiosis, and this will tell you, okay, don't go ahead with stepidotomy. Stay back and treat the patient with a sodium fluoride, right? Right. What is Jelly's test? This is one more tuning fork test that you can do, right? So when you have otosclerosis, let me just draw the ossicles. You have the malleus, you have the incus, and then you have the stapes, right? So now this is fixed, right? So what happens in Jelly's test? Can anyone tell me what is Jelly's test? It is basically testing your bone conduction, right? So what happens in Jelly's test is, when you have a normal ear, you do a bone conduction, and then you increase the pressure in the external auditory canal, and then you do a bone conduction, right? So this will, what will happen? The bone conduction, anybody? Okay, so Gillis test is basically done in otosclerosis. So when you talk about the conduction, the bone conduction tends to increase, right? So the hearing becomes, what happens? Right. So Gillis test, when you look at Gillis test, the in otosclerosis, the stapes does not move. So there is no change when you increase the pressure in the external auditory canal. Whereas in a normal ear, the hearing may become better. Right. So that is what is Gillis test. So now let's come to pure tone audiometry. You see a Carhart's notch on pure tone audiometry. That is a dip at 2 kilohertz. A dip at 2 kilohertz is something that you see in otosclerosis. When you talk about impedance audiometry in otosclerosis, what do you see? You see a reduced compliance. Yes, you see a reduced compliance whenever you change all the pressures, right? And then what else do you see? You see a stapedial reflex. Initially, it will be present. Later on, the stapedial reflex will be absent. So remember, what is the reflex center for stapedial reflex? It is the olivary nucleus. So superior olivary nucleus is the reflex center for stapedial reflex. So when you talk about speech audiometry, so what are the two components of speech audiometry that you have? You have the speech reception threshold and the speech discrimination score. Remember, speech audiometry is worse in cases of a retrocochlear hearing loss. Okay, so whenever there's a retrocochlear lesion, for example, tumors of the auditory nerve, the speech audiometry is worse. So when you're talking about otosclerosis, it's related to the middle ear, and sometimes it can be related to the cochlea as well. So the speech audiometry in such cases would be good. Okay, so there is no problems in speech audiometry, especially the speech discrimination score. It will be somewhere in the range of more than 70%. Right. So when you talk about otoacoustic emission is related to the outer hair cells. So otoacoustic emission will be, what happens in otosclerosis? Will it be present or absent? We'll talk about the pathway of otoacoustic emission. It will be absent in cases of otosclerosis. It is negative in case of otosclerosis. And imaging can be done to find out the thickness of the foot plate in cases of otosclerosis. So when you talk about treatment, you have three important treatment modalities, that is hearing aid, sodium fluoride, and surgery. Here, these three options should be given to the patients, especially if the patient is not in the active phase. You can give hearing aids and surgery as two options. If the patient is in active phase, you can give sodium fluoride, that is 20 to 40 milligram per day. So what does sodium fluoride do? It can increase the osteoblastic activity, it reduces the osteoclastic activity, and along with this, what does it do? It decreases the activity of the enzymes, that is toxic enzymes is reduced, and it increases the mature bone formation. So this is what sodium fluoride does, and this has to be given in cases of active cases, right? So when you talk about surgery, you need to know what are the contraindications for surgery. So what are the contraindications for surgery? You have the only hearing ear, association with Meniere's disease, patient not willing for surgery. So these are a few contraindications, absolute contraindications for doing a stepidotomy. So what you see here in this image is something that I would like to show you. Stepidotomy being already done. You see, this is the round window niche, just to fresh up the anatomy there. You have the incus here. This is the long process of the incus. You can see the chorda tympani now pushed down. You can see the Teflon piston nicely going into the oval window, and you can also see the facial nerve in close proximity to the oval window. So this is about the anatomy, what you see in this particular image. So we've already discussed this answer, that is you do a stepidotomy in the right ear. Now if I were to ask you, why does this Carhart's notch happen? So why does Carhart's notch happen? So the Carhart's notch happens because the resonance frequency of the middle ear and that of the ossicles is maximum at 2 kilohertz. So when the ossicular chain is fixed, there is a dip in the bone conduction, right? So when you talk about bone conduction, there are three ways by which bone conduction occurs. So what are the three ways by which bone conduction occurs? One is the compressional mechanism. The second way by which bone conduction occurs is the inertial mechanism. And the third way is the osteotympanic mechanism. Right? So compressional is the bone vibrates, the cochlea vibrates. Inertial mechanism is there is movement of the foot plate and there is a certain lag in the movement as far as otosclerosis is concerned. That is why the inertial component is lost in cases of otosclerosis. Then you have the osteotympanic, that is the bone vibrates, the air molecules in the external auditory canal vibrate, and thereby it leads to the conduction pathway, right? So you have these components by which bone conduction occurs. So if I were to tell you does this patient have otosclerosis or does this patient have sensory neural hearing loss? You have a mixed hearing loss here, right? So does this patient have a sensory neural hearing loss? No. Why? So if there is otosclerosis, there will be asymmetry between the air conduction and the bone conduction. You see this bone conduction is dipping here, right? Whereas the air conduction is not showing any dip. So if the air conduction and the bone conduction dips are symmetrical, for example, the air conduction dip also happens symmetrically to the bone conduction, think in terms of a sensory neural component, think in terms of a cochlear otosclerosis, which is a possibility in certain circumstances. Let's come to this multiple choice. We can run through this. It's very, very simple. You just need to imagine the organ of Corti and that is done and dusted, right? So when you look at this, mark the correct statement regarding inner and outer hair cells, right? So you have the inner hair cells, which are single in row, transmit auditory impulses. True or false? This is inner hair cells are always single row. So this is true. Outer hair cells are 3 to 4 rows and modulate inner hair cell function. True or false? This is true. Outer hair cells are responsible for tectorial membrane movement. Oh, you think about it, right? So does it happen? This is false. I'll tell you why. OHC to IHC ratio, they've already given it away in the previous two choices, right? So this is true. So you have 1, 2 and 4 which are correct. Straight away the answer comes, right? So when you look at the organ of Corti, let's discuss a little bit about the organ of Corti here. You see you have 3 rows of outer hair cells, single row of inner hair cell. You have the tectorial membrane sitting on the top. You have the basilar membrane sitting on the bottom, right? So when there is conduction, the perilymph moves. When the perilymph moves, there is movement of the basilar membrane. So when there is movement of the basilar membrane, the outer hair cells move. Right? So when the outer hair cells move, it's like a pre-neural input to the inner hair cells. That is, it amplifies the sound to be presented to the inner hair cells, which eventually transmits the electrical impulses. Got the point? Now, what are the functions? Basilar membrane, what does it do? It is responsible for tonotopicity. So if you look at the inner ear, you have basilar membrane right from the apex, from the base to the apex. Each and every part of the basilar membrane is responsible for a particular frequency. That is tonotopicity. Okay, so each and every point of the basilar membrane is responsible for a particular frequency. That is tonotopicity. When you talk about outer hair cells, it amplifies and tunes the sound and then presents it to the inner hair cells, which eventually causes mechano-electrical transduction of sound. And when you talked about tectorial membrane, it is responsible for frequency selectivity. Stria vascularis is responsible for cochlear homeostasis, and spiral ganglion is responsible for neural transmission. So when you look at the functions, these are the particular functions. And if you look at a few other important questions, what is the neurotransmitter that gets transmitted for the conduction? It is glutamate. Remember glutamate as one of the answers. Let's look at the next question. You have a patient who presents to the OPD with complaints of hearing loss and can understand only amplified speech. Amplified, you need to shout to the patient. So what will be the degree of impairment as per WHO classification of hearing loss? Okay, the answer here is severe. I'll tell you why. So if you look at this present, the classification that has been put forth by the WHO, you see 0, there is no impairment. As far as the intensity of the sound is concerned, it has to be 25 decibels or better, so the patient is able to hear well. There is very slight hearing or no hearing problems, even whispers the patient is able to hear. When you talk about slight impairment, it is in the range of 26 to 40 decibels, or you can call it mild impairment. And here the patient is able to hear and repeat words spoken in normal voice at 1 meter distance. So you can still consider these as normal people, don't give them hearing aids straight away. When you talk about moderate impairment, it is in the range of 41 to 60 decibels, and the patient is able to hear and repeat words. Mark there, able to hear and repeat words using a raised voice, right? Raised voice. Look at the next one, shouted. Able to hear some words when shouted into the better ear. So this impairment requires a severe degree or a high degree of amplification, and when you're looking at a severe impairment, that is 61 to 80 decibel hearing loss, right? So this is the reason why this is the answer. You need to amplify sounds many a times for a patient with severe impairment to hear. And definitely when you look at profound impairment, they definitely require some sort of hearing amplification device. So we just ran through that multiple choice question. What you need to remember here is this particular classification, which will be useful to you if this type of a question is asked. Most commonly asked questions. So if you look at the auditory pathway, straightforward, I think all of you would be well versed with the auditory pathway, and the mnemonic for that will be echolaima. So when you talk about echolaima, you have the eighth nerve, you have the cochlear nucleus. What do you have here? You have the olivary complex, the lateral lemniscus, the inferior colliculus, medial geniculate body, and eventually you have the auditory cortex. So when you talk about auditory cortex, you're looking at 41, 42, association is 22 and 52, right? So this is how the function or the auditory pathway in sequential order goes. So what you need to remember in the auditory, this sort of translates into the BERA as well to some extent. There have been quite a few number of questions as far as BERA is concerned. So you can definitely put this options in this particular order. So you have the cochlear nerve first, and then you have the nuclei. Sorry about the options. This has to be 3, 4, 5, and 6. And so it is 1, right, 4, and then olivary complex 2. So I think the first option is the right option here. Okay, so this is how you go about. If you remember this auditory pathway, definitely this auditory pathway is one area which has been asked over and over again, and this can be translated to the BERA as well. So you need to remember this auditory pathway in detail. This is the image of the same which has been put forth. So you need to understand this image in detail. So next one is related to BERA, right? So when you talk about BERA, so what you need to understand here, once again, you have 3 important responses. When you talk about the evoked response audiometry, you have 3 important parts. One, you have the BERA, then you have the middle latency response, and then you have the late latency response as far as the evoked audiometry is concerned. So when you talk about BERA, up to 500 milliseconds you can measure, right? So when you talk about BERA, it is in the initial 10 milliseconds. Middle latency response is between 10 and 50 milliseconds. And when you talk about the late latency response, it goes on from 50 milliseconds all the way to 500 milliseconds. Few points to remember here. BERA is not affected by anesthesia, not affected by sedation, not affected by sleep. Middle latency response and late latency response affected by sleep, affected by anesthesia, affected by sedation. What stimulates BERA? you have the pathway which is already mentioned there. We will discuss that. It has got 5 important waves: 1, 2, 3, 4, and 5. What constitutes the middle latency response? It is more to do with myogenic origin. What constitutes the late latency response? It is more to do with higher centers. When you talk about higher centers, you're thinking about hippocampus, you're thinking about limbic cortex, you're thinking about thalamus. These are responsible for your late latency response. So this late latency response is also called as CERA, that is cortical evoked response audiometry, right? So when you talk about the various waves of the BERA and the intervals that you need to talk about, or the latencies that you need to talk about, it is important. So when you talk about wave 1 and wave 2, it is related to the nerve. Okay, so you have the distal end of the nerve and the proximal end of the nerve. When you talk about wave 3, it is related to the cochlear nucleus. When you talk about wave 4, what is the next one? Olivary complex, right? And eventually it drops down to lateral lemniscus and inferior colliculus. Okay, so this is how the pathway goes. Once again, you can label this as 1, 4. It is similar to what you saw earlier, right? So 1, 4, 2, 5, no, yeah, 5 and 3, right? So option 1 is the answer here. So remember, now let's talk about the latencies, right? So you have what needs to be measured on BERA is the latency. You have 1 to 3 wave intervals. You have 3 to 5 wave intervals. You have 1 to 5 intervals. And then you have the interaural latency of wave 5. And also whether the wave 5 is present or absent. Absent is always abnormal. Remember that. Absent is always abnormal. When you talk about 1 to 3, normally it is 2 milliseconds. The latency is approximately 2 milliseconds. If it is more than 2.4, it's considered abnormal. The latency between 3 and 5 is also 2 milliseconds. If you're looking at more than 2.4, it's considered as abnormal. The latency between 1 and 5 is 4 milliseconds, right? And 4.4, more than 4.4 is considered to be abnormal. Okay, so and when you talk about interaural latency of wave 5, it should be within 0.3 milliseconds. If it is more, it is abnormal, right? It should be less than 0.3 milliseconds. If it is more, it is abnormal. So remember, these latency periods are important when you consider hearing loss as well, right? So these are the things that you need to remember in BERA. Third important investigation, you've seen BERA, right? What is the sequence as far as otoacoustic emission is concerned? So the term otoacoustic emission is related to the outer hair cells. We've already discussed what outer hair cells do. They amplify the sound. It's like a pre-neural input. They amplify, tune the sound, and then present it to the inner hair cells, right? So what should be the pathway as far as otoacoustic emission is concerned? You have spontaneous otoacoustic emission and evoked otoacoustic emission. So among the evoked otoacoustic emission, you have TEOAE, that is transient evoked otoacoustic emission, and also DPOAE, that is distortion product otoacoustic emission. You don't need to know too much in detail about these otoacoustic emission, but remember, of these, the most important or the most measured one is the distortion product otoacoustic emission. So when you talk about the pathway for otoacoustic emission, what are you looking at? Let's see this particular diagram. It's so clear. It is your normal conduction pathway, right? Goes through the external auditory canal, hits the tympanic membrane, goes through the ossicular chain, vibration of the fluid, and eventually the basilar membrane, and eventually the outer hair cells move. The outer hair cells transmit the amplified tuned sound to the inner hair cells. Inner hair cells convert it electrical pathway. It goes all the way to the brain. So this is how otoacoustic emission pathway is. So now let's understand what happens if there is any pathology in this region. Otoacoustic emission will be absent. You have wax in the external auditory canal. or any pathology in the external aortic canal, it can be absent. If there's a perforation in the tympanic membrane, it can be absent. If there is ossicular fixity or ossicular discontinuity, it can be absent. So then, similarly, if the outer hair cells themselves are absent, it can be absent, right? So, as simple as that, this otoacoustic emission pathway goes this way. Remember, distortion product otoacoustic emission is the easily measured or the best to be measured, and you have all these reasons why otoacoustic emission can fail or the test can be abnormal. Right. Let's look at this particular question. A 14-year-old is brought to the outpatient able to hear the sound of speech but has difficulty in understanding words. So if the PTA and BERA are inconsistent with each other and the PTA is normal, the pure tone audiometry is normal, her middle and cortical responses, middle latency and cortical responses were absent. So what is the likely diagnosis? This has got to be something to do with the nerve. Okay. So this has got to be something to do with the nerve. Remember, there is one set of disorders which is called as auditory neuropathy. So this is the diagnosis in this case. I'll tell you why. So what happens in Michael's aplasia? What is Michael's aplasia? This is complete labyrinthine aplasia. So when there is complete labyrinthine aplasia, where is the question of PTA? Right? Where is the question of brainstem evoked response audiometry? It will usually be absent. Okay, there the results are inconsistent with each other, right? Right. Let's look at malingering. Malingering is out of the way altogether, right? So malingering, you will have a normal response in most of the cases. When you look at cochlear otosclerosis, once again you have a sensory neural hearing loss. The PTA will not be normal in this case. What is missing in this may be a otoacoustic emission. This has not been mentioned here, right? So when you're looking at an auditory neuropathic disorder, what happens to the BERA? Can anyone answer that? What happens to BERA? What happens to otoacoustic emission? What happens to middle latency cortical responses? Like it is mentioned in this particular multiple choice, middle latency and cortical responses are absent. What happens to otoacoustic emission in auditory neuropathy? Auditory neuropathy, the name itself says that there is some abnormality in the auditory nerve, right? Auditory nerve comes after the outer hair cells. So outer hair cells are normal. So otoacoustic emission will be present. Auditory nerve is affected, so BERA will be absent. Okay. So this is how you can diagnose a auditory neuropathy. The two most important investigations as far as auditory neuropathy is concerned is BERA and OAE. So remember, BERA absent, otoacoustic emission present, think in terms of auditory neuropathic disorder. Okay, so that is what we have discussed in this particular multiple choice question. Now let's come to a few other. Let's shift off a little bit from the audiological aspects and let's come to complications of chronic otitis media. Important question here. All of the following are complications of chronic otitis media in the following, except, or the question is, can be framed in a better way. What are the signs or whatever you can mention it, right? This question has not been framed properly. But if you were to look at this particular question, what would you answer it as? Absolutely correct, Stardust. Battle sign is the right answer, right? So I will tell you, let's enumerate what are the complications here, right? So when you talk about complications, you have intratemporal, extratemporal, and intracranial complications, right? So three very important, or in a better way, this has been classified. You can have extracranial, extratemporal as well. Okay, so extracranial, extratemporal complications. Okay, right. So intratemporal, let's make it simpler, and intratemporal, extratemporal, and intracranial complications. So when you talk about intratemporal complications, what are you looking at? You are looking at facial nerve paralysis. What else are you looking at? You are looking at labyrinthitis. All the itis come here. You are looking at mastoiditis. You're looking at petrositis. Did I miss anything? Anybody has anything else to tell? You can also have hearing loss put here, right? That can be because of erosion of structures, right? So intratemporal complications, these are all intratemporal complications. Let's not go into description. So when a patient, they can give you a clinical scenario on petrositis or Gradinego syndrome. So when you talk about Gradinego syndrome, you have the fifth nerve involvement, the sixth nerve involvement, along with persistent ear discharge. So remember, a clinical scenario can be put in such a way that petrositis can be a diagnosis, right? So one of the commonly asked questions. So when you talk about labyrinthitis, you're looking at vertigo beyond 24 hours. Catch this point there. When you're looking at mastoiditis, they might give a 3-point tenderness positive. They might give a pinna being pushed forward along with swelling in the mastoid. So that will help you in diagnosis. Facial nerve paralysis, they might give you a clinical scenario with ear discharge and eventually a image with a patient having a facial nerve, low motor neuron type of facial nerve paralysis. That is the way they can give you a question. So when you talk about extratemporal complication, these are all the extratemporal complications that you have. What is Wild's abscess? This is a post-oral abscess, right? What is zygomatic abscess? Let's put it in a better way here. Post-oral abscess, right? So when you talk about zygomatic, the name itself says it is in the zygomatic bone, right? Or related to the zygomatic bone. Meatal abscess. What is meatal abscess? It is within the meatus. It's a type of a subperiosteal abscess. It is also called as Lux abscess, right? So when you talk about Siteli's abscess, the pus trickles along the posterior belly of the digastric and produces an abscess in the neck along the digastric muscle. When you talk about Bisol's abscess, you look at the other muscle that is there behind. That is the sternocleidomastoid muscle. So you have the sternocleidomastoid. If pus is present along the sternocleidomastoid, think in terms of Bisol's abscess. If it is present along the posterior belly of digastric, think in terms of a Siteli's abscess, right? So each and every abscess can be one question in a different way. Okay, so they might give you a question. What you saw was a battle sign in this case. They may give you questions based on these important complications. So what I've enumerated here is lateral sinus thrombosis, which is one of the very important questions, right? So when you talk about fever in lateral sinus thrombosis, you have a picket fence type of fever, right? It does not reach the baseline. So let me ask you one question here. What is the type of fever you get in meningitis? What is the type of temperature you get in intracerebral abscess? Can anyone answer that? With relation to the year, of course. With relation to the year. Meningitis will produce high grade fever, whereas intracerebral abscess can sometimes produce hyponormal or subnormal, let me correct that, can have subnormal temperatures. Okay, and then you have lateral sinus thrombosis, which produces a picket fence type of fever. That is, it produces up and down, not touching the baseline. Think of lateral sinus thrombosis. They present to you with headache, deep-seated pain, Grisinger's sign. So what is Grisinger's sign? That is edema of the mastoid due to thrombosis of the mastoid emissary vein. You have Crowe-Beck test. Suppose there is thrombosis, lateral sinus thrombosis, or on one side, right? So what happens when you compress the internal jugular vein on the opposite side? There will be engorgement of the retinal vessels. That is Crowe-Beck test, also known as Lillie-Crowe test. Okay, then you have Toby-Ayer test, which basically is measured on manometry, right? So compression on the affected side does not increase the pressure. Compression on the opposite side or the normal side increases the pressure. Then you can have papilledema and delta signs. You see two important options were there from lateral sinus thrombosis. In this case, you have Grisinger's sign, delta sign. Delta sign is basically absence. You can because of the thrombus in the lateral sinus or the sigmoid sinus, there is a sort of a filling defect that is known as empty delta sign. Right, let's come to the next question. We have involvement of the jugular foramen leads to which of the following? For this, you need to know the anatomy of the jugular foramen. As simple as that. Nothing more to do apart from anatomy, right? So when you talk about the anatomy of the jugular foramen, think of it as three important parts, right? The first part, or the lateral most part, contains the jugular bulb along with meningeal branch of occipital artery. Meningeal branch of occipital artery, right? So what does the second compartment contain? Anybody? What does the second compartment contain? I'm drawing it in yellow, so you should get a clue as to what it is, right? You have the lower cranial nerves, right? The 9th, the 10th, and the 11th cranial nerves, along with the meningeal branch of ascending pharyngeal artery. And in the last compartment, what do you have? You have the inferior petrosal sinus, and there can be emissary veins, right? There can be emissary veins anywhere, but this is how the anatomy lies, right? So the 9th, 10th, 11th cranial nerves, this is what the question is all about. So if you look at the options in this case, what do you have? Loss of taste from anterior 2/3 of the tongue. Where does it come from? Which nerve? Loss of taste from the anterior 2/3 of the tongue. Yes, absolutely correct, Stardust. Okay, so you have inferior petrosal sinus in the mid. Yes, chorda tympani. So chorda tympani is a branch of the 7th nerve. So rule out this. Loss of sensation from the anterior 2/3 of the tongue. Produced by which nerve? This is, they're talking about general sensation. This is taste sensation. Waiting. Yeah. Yes, absolutely correct. So lingual is the right answer. So you have the lingual once again. Which nerve? 5th nerve, right? And then you're talking about loss of sensation from posterior 1/3 of the tongue and loss of taste and sensation from the anterior. This is already ruled out. So this is the answer, right? So which nerve? 9th nerve. So 9th nerve is responsible for sensation to the posterior 1/3 of the tongue, right? Whereas the motor supply in that area, that is that oropharyngeal area, oropharyngeal muscles of the pharynx, you have the 10th nerve coming into picture, but general sensation is by the glossopharyngeal nerve, right? So vagus is responsible for your muscles of the pharynx, the larynx, as well as, yeah, so basically muscles of pharynx and larynx is supplied by the vagus. And when you talk about the spinal accessory nerve, it is basically the trapezius and the sternocleidomastoid. So the answer is straightforward because you're able to decipher what the anatomy is all about as far as jugular foramen is concerned. Now let's come to the next question, back to audiology again. So you can expect a lot of questions on audiological parameters. So be thorough with audiological parameters, hearing loss, hearing rehabilitation as far as ENT is concerned, right? So which of the following tests will you combine if OAE is absent in this patient, in a particular patient? Can anyone tell me? You have pairs of answers, right? So here what you need to think about is, you need to think about, one is the subjective test and you need to think about objective tests. So let's look at what are the subjective tests in this answer. You have 4 options here. What are the subjective options? What are the objective options? Tympanometry, objective. Speech audiometry, you will definitely try to find out, right? So when you talk about speech audiometry, it has got 2 important components, that is speech reception threshold and speech discrimination score. Someone has mentioned, Stardust has mentioned B and C are objective. What is free field audiometry? This is done in children in the age of 6 months maybe to 12 months, you can do this test, right? You cannot do a pure tone audiometry in children. Okay, right. D is definitely subjective, right? So B and C is objective, I accept. The reason being, when you look at this particular test, that is free field audiometry, you have no way of doing a pure tone audiometry in children. So what do you look at is you keep speakers, right? You keep speakers, you sort of triangulate. You keep speakers on both the side, and then based on the increasing intensity of sound, you try to find out whether the child has got hearing loss or not. You can say this as a sort of an objective test as well. But remember, if the child does not respond, what are you going to do? What is the other test that you can do? Child gets tired. Okay, I don't want to listen to sound. What do you do? Visual reinforcement audiometry. So you add a toy along with that. Okay, so you can add a toy along with that. So the answer in this case would be B and C. So when you talk about otoacoustic emission is absent, you can do a free field audiometry along with a tympanometry, right? So now let's discuss a little bit about speech audiometry. So what do you understand by SRT and speech discrimination score? You have spondy words being given to the patient. They have to answer at least 50% at a particular intensity. You find out the speech reception threshold. It has to be very close to the pure tone threshold, right? So when you talk about speech discrimination score, what do you do? They are able to differentiate here. What do? You give? What do you? What type of words do you do? Phonetically balanced, right? So phonetically balanced list is given to the patient, and they should be able to differentiate the two sounds, and they should be able to discriminate. So when you talk about discrimination, 100% discrimination is usually normal, right? Yes, absolutely correct status. Speech reception threshold is intensity at which patient is able to repeat 50% of the words, whereas phonetically balanced list is given in case of speech discrimination score, where they should be able to differentiate between two similarly sounding words, right? And 100% is regarded as normal. Somewhere in the range of 60 to 70% and above is a cochlear type of hearing loss, and if it is poor in the range of 10 to 30%, then you're looking at a retrocochlear hearing loss, right? So that is about this question. Now let's come to the next question. A patient complains of decreased hearing in the left ear. His audiogram is given below. What would be the tuning fork test in this patient? So here what you need to understand is what type of a hearing loss is there in this patient, right? This is a sort of a twisting question. You have a false negative Rene here. Why do you have a false negative Rene? You have a severe sensory neural hearing loss, unilateral severe sensory neural hearing loss, provided masking has not been done, right? If the patient has been masked, it would be a slightly better response, right? So downsloping accepted, but remember here, if you are given a tuning fork test, you have to find out what the degree of hearing loss is, right? So this is a severe sensory neural hearing loss, right? So when you talk about severe sensory neural hearing loss, it can go to the opposite side. So what would be the answer in this case? What will happen to the Renes and what will happen to the Webers? Left side SNHL. So it has to, the Webers has to be lateralized to the right. Okay, Webers let some one of these two answers. What about false negative Rene? Left ear Rene, what happens to it? Negative, right? It can be false negative Rene. So this could be the answer in this case, basically because of the fact that they have not mentioned about masking. And if you're looking at a Rene's test, which I've already discussed, it becomes a false negative Rene. It gets conducted to the opposite side. So bone conduction can become better than air conduction in tuning fork tests. Okay, this is what I've already discussed. So the answer would be left ear Rene's negative and Weber's lateralized to the right. Okay. Okay, straightforward question. Yes, correct. So what is the grade of retraction in this? An image can be given like this, right? So grade 1, 2, 3, 4. Okay, I might not have stuck to the question that was asked in INI-CET, but I have an image of a retracted tympanic membrane here. What is the grade of retraction? What you need to see here is whether it is plastered or not plastered, right? On the promontory. Correct. So the grade is 2. So why is the grade 2? Okay, so you have two important classifications here. One is the SAID classification for pars tensa and TOS classification for pars flaccida. So when you talk about SAID's classification for pars tensa, you have 1, 2, 3 and 4. Okay, so when you talk about 1, it is just a mild retraction. There's no significant prominence of whatever you see in this particular image. When you talk about 2, there is distortion of the cone of light. Along with that, there is prominence of the lateral process of malleus. You see the malleus, the handle of malleus has gone significantly, it has retracted inwards. But when you talk about prominence of lateral process of malleus, prominence of the anterior and posterior malleolar folds, prominence of the annulus, it becomes a grade 2, right? So this is what is there in this particular image. What about grade 3? Grade 3, it is plastered onto the promontory. The incudostapedial joint is extremely prominent, totally plastered. You can see the architecture of the middle ear, but when the patient does Valsalva, you are able to see that the tympanic membrane moves. If you're looking at grade 4, so remember grade 3 is also known as atelectasis. And when you talk about grade 4, it is adhesion, right? Atelectasis means the tympanic membrane still moves on Valsalva. When you talk about grade 4 or adhesive otitis media, it is totally plastered onto the promontory. And when the patient does Valsalva, the tympanic membrane does not move at all. Okay, so that is the grades of retraction of the pars tensa. When you talk about grade of retraction of the pars flaccida, let me tell you in this image itself, I had a slide on description of each one of them, but it's easier to describe with this image, right? So when you talk about pars flaccida, what happens? You see this area? This is pars flaccida. A small dimple over the pars flaccida is TOS grade 1. When you are able to see the prominence of the neck of the malleus, it becomes grade 2. When there is a limited outer attic wall, this attic wall, there is limited erosion of the attic wall, it is grade 3. And when there is significant outer attic wall erosion, it is termed as grade 4. Hope this is clear to you. SAID's classification for pars tensa, TOS classification for pars flaccida. 1 is mild distortion of the cone of light, 2 is distortion of cone of light along with prominence of lateral process of malleus, prominence of anterior posterior malleolar fold, significant retraction of the handle of malleus and prominence of the annulus. Grade 3 is atelectasis, that is the tympanic membrane is plastered onto the promontory but moves with Valsalva. Grade 4 is adhesive otitis media, that is it does not move with Valsalva. Right. TOS classification, 1 is a small dimple, 2 is prominence of the neck of the malleus is seen through the retraction. Grade 3 is limited outer attic wall erosion. Grade 4 is significant outer attic wall erosion. Right, so this is what I mentioned. Now let's come to this. Okay, going into the vestibular system now. Okay, so you have a little more of vestibular system. So what do you have here? A patient was found to have acute vertigo associated with horizontal nystagmus with slow component towards the left. In which of the following conditions would you see this finding? Keywords here: horizontal and towards which side the nystagmus is. I'm just going to tell you a few rules that you need to remember as far as this type of question is concerned. Acute vertigo, type of nystagmus, which side does it go to? Anybody? Right. So when you talk about nystagmus, it usually is towards the fast face, right? So you have a horizontal nystagmus. So now let's discuss a little bit about nystagmus. You have horizontal nystagmus. So what produces a horizontal, and at times you have a torsional component as well, that is the lateral semicircular canal. If there is involvement of the superior semicircular canal, it produces a vertical downbeat torsional. Okay, so vertical downbeat and torsional. If you are looking at a posterior semicircular canal, you are looking at a vertical upbeat torsional nystagmus. Is this clear to you? So when you talk about nystagmus, so this is what you actually visualize, right? So horizontal semicircular canal you have, horizontal nystagmus you have in lateral semicircular canal. Superior you have a vertical downbeat nystagmus, and posterior semicircular canal you have a vertical upbeat torsional. Remember, when you talk about nystagmus, this is how it presents. So when you talk about semicircular canal, most often you'll have a torsional component. So when you're looking at central type of nystagmus, you are mainly looking at a vertical nystagmus, will not have the torsional component, and at times when there is cerebellar involvement, there will be a pendular type of movement. Is that clear so far? So you have a horizontal nystagmus. So this is ruled out. Superior canal BPPV is ruled out. You have a vertical component there. Now the question comes, the slow component is towards the left. So you have the nystagmus is always towards the fast component. So what would be the answer in this case? Which side is hypoactive? Fast component to the right side. Correction. Left. Okay. So whenever the left labyrinth is hypoactive, there will be a correction to the opposite side. The fast face is always towards the opposite side of a hypoactive labyrinth. Remember that. So a hypoactive labyrinth always produces a fast component to the opposite side. I'll put in one more point here. Okay, I mentioned about hypoactive. What about hyperactive? So you have a hyperactive labyrinth, like irritative phase of Meniere's disease will always produce a fast component to the side of lesion. So imagine the patient has got a right Meniere's disease. The fast component will be towards the irritative side, right? So remember, irritative lesions, same side. Hypoactive lesions, opposite side, or paretic lesions, opposite side. Horizontal nystagmus in lateral semicircular canal involvement. Remember, a torsional component may also be present. When there's a vertical downbeat torsional nystagmus, think in terms of a superior canal. Up produces down. Posterior canal produces up. So vertical upbeat torsional. Okay. So few rules to remember here. Type of nystagmus, where the fast component goes, what happens when the labyrinth is hyperactive or hypoactive. A few points about central versus peripheral. Okay, so what do you know about latency period? What happens in central nystagmus? No latency period. Peripheral nystagmus has got a latency period. Fatigability, not fatigable. Fatigability is present in cases of a peripheral nystagmus. Direction change, direction or plane of nystagmus along the line of the canal, whereas it can be multi-directional in cases of multi-directional in case of central nystagmus, whereas it will be Does the fast component, that is the what do you call, that is how a nystagmus is denoted, right? You're not talking about the slow phase, fast phase. Whenever a nystagmus is mentioned, it is mentioned in the direction of fast phase. The question was a little tricky there. They have mentioned about the slow phase of nystagmus, right? So for example, let's take the right side as paretic. What is going to happen? So you're doing a nystagmus testing, right? So if the right side is paretic, what will happen if the patient has to suddenly look to the opposite side? You're mainly looking at the vestibular ocular reflex. When the patient has to look suddenly to the opposite side, it does not happen immediately. Why? The right side is hypoactive and it does not respond. But the left side, it takes some time for it to act. So when it acts suddenly, there will be a sudden jerk, right? So the direction of nystagmus is always depicting the fast phase. So that is why I told you, if there is a irritative lesion, let me take, for me it's easy to describe with the right side. So if there is a paretic lesion on my right side, what will happen? The direction of the fast phase will be towards the left. If I have an irritative lesion of Meniere's disease on my right side, the direction of fast phase will be towards the right. Hope that makes it clear, Stardust. Is it clear? Yes, okay. Thank you. Right. So, multidirectional peripheral nystagmus along the lesion, right? So, along the direction of the semicircular canal. So, when you're looking at lateral semicircular canal, it's a horizontal nystagmus, right? So, when you talk about, once again, when you talk about lateral semicircular canal, it's all dependent on the stereocilia and the kinocilium. Remember, the kinocilium is very close to the vestibule in cases of lateral semicircular canal, whereas in posterior and superior semicircular canal, they are away from the vestibule. So when you have an ampulofugal movement, there is depolarization as far as superior and lateral semicircular canal is concerned, and there will be a whenever there's an ampulopetal movement in cases of a lateral semicircular canal, there will be depolarization. Okay, one more important point there. Okay, so direction and plane of nystagmus, it can waver as far as central nystagmus is concerned. When you talk about peripheral nystagmus, it is towards a particular direction. Direction change present in central, absent in peripheral. Does visual fixation have any response in central? No. But when the vision is fixed, the peripheral nystagmus disappears. So these are a few differences between central and peripheral nystagmus that you need to remember, and you can apply this in the multiple choice questions as and when questions on vestibular system pertaining to nystagmus can be asked. Okay, now let's not look at the image alone. Okay, let's, histopathology sometimes can be very tricky. Okay, Dr. Ranjana might not agree with me. Okay, it is very easy for her to diagnose histopathological images. But let's not look at the image for the time being. Okay, so following is the histopathology slide of an operated mass. Operated mass. Patient has been operated. Okay, of a 50-year-old man. Okay, so a 50-year-old man who gave history of tinnitus, hearing loss in the right ear for the past 7 years. So it has been a long standing ailment for which the patient has gotten operated. If you look at the ear symptoms, tinnitus and hearing loss is present in this patient. There is some loss of balance and persistent headache present in this patient. Nowhere have they mentioned about ear discharge. Okay, nowhere mentioned about ear discharge. Elderly male, operated. Okay, his audiometry showed moderate sensory neural hearing loss in the right ear. So what would be the diagnosis? Not looking at the image, just by looking at the clinical picture, what would you diagnose the patient as? What would you diagnose the patient? . Straightforward, right? Acoustic neuroma or vestibular schwannoma. Straightforward diagnosis, right? In this image, what you are seeing is the classical Antony A cells and Antony B cells. So Antony A cells are a nice palisade pattern of cells arranged, and sparsely arranged cells are Antony B cells. Antony A, Antony B, right? Meniere's disease straight away ruled out. Okay, so when they say moderate sensory neural hearing loss, audiometry is not mentioned here, but you look at the clinical presentation itself, it is not episodic, right? It is a progressive illness which has been operated. So what would be the treatment, surgical treatment, if you were looking at Meniere's disease? You have medical treatment and surgical treatment in Meniere's disease, right? So what would be the medical treatment? What would be the surgical treatment? Medical treatment more often is given for maintenance as well as for acute phases. Surgical treatment can be done if there is hearing loss. Yes, resection of the tumor has been done. Okay, so vestibular schwannoma is the diagnosis here. Okay, so now let's look at the options. Meniere's disease, I'm not going to discuss about histology, right? So you have two important things here to discuss, that is medical treatment and surgical treatment. So when you talk about medical treatment, you're looking at benzodiazepines, right? Benzodiazepines, and then you have cinnarizine, which is the most commonly used drug, and along with that you have promethazine, right? Also you can have in the acute phases, you can have prochlorperazine. Okay, so this is given as medical therapy for Meniere's disease in the acute phase. When you talk about surgical treatment of Meniere's disease, what is the surgical treatment? You have chemical labyrinthectomy. It is actually not a surgical treatment. It is more often to do with a medical treatment. You have chemical labyrinthectomy. You give intratympanic gentamicin to destroy whatever, in cases of sensory neural hearing loss. Remember, these patients are already having sensory neural hearing loss in Meniere's disease, and in those cases, you can give intratympanic gentamicin and destroy whatever vestibular epithelium is left, so that the patient is relieved of the vertigo, right? Intratympanic steroids can be given in cases of acute phases of Meniere's disease as well. So when you talk about surgical treatment, labyrinthectomy and endolymphatic sac decompression are the two treatment modalities that are available. Endolymphatic sac decompression is still controversial as far as treatment aspect is concerned. When you're looking at a labyrinthectomy, surgical labyrinthectomy, it is more or less less preferred, you can say, less preferred in cases of Meniere's disease, basically because of the fact that intratympanic therapy has come in a big way, right? Right. So now let's look at glomus jugulare, right? Glomus jugulare will also present with tinnitus, will also present with hearing loss, right? And it is also a slow growing tumor. It can also be operated. Most often, when you look at glomus jugulare, it presents to you with conductive, and then it progresses on to a mixed type of hearing loss, right? Because glomus jugulare occurs in the jugular foramen region. So from the jugular foramen, it comes to the middle ear, from the middle ear, and then it can erode various structures. So it starts off with a conductive hearing loss, and then it can go on to a mixed hearing loss. You look at the audiometric finding here, it is moderate sensory neural hearing loss, pure sensory neural hearing loss. When you look at it, you're looking at a vestibular schwannoma, right? So what about cholesteatoma? When you're talking about glomus jugulare, Zellballen. Okay, this is a characteristic word that you see. You see well circumscribed nests of round oval cells, right? Round oval giant cells in nests. This is called as Zellballen, and it is very characteristic of a glomus tumor. That terminology has more or less gone away, and now it's called as paraganglioma. What do you see in a cholesteatoma? Can it be a cholesteatoma? No. You see, there's no history of ear discharge. Agreed that it can be a congenital cholesteatoma, but congenital cholesteatoma does not present usually at 50 years of age. Okay, and the characteristic moderate sensory neural hearing loss. It usually presents with a conductive hearing loss. It can progress on to a mixed hearing loss, right? So when you talk about cholesteatoma, what do you have? You have the epithelium. What is that? That is the matrix. Then you can have the connective tissue, which forms the perimatrix, and then most inside, or the first important structure you have is the cystic component. Okay, cystic component along with epithelium, which is the perimatrix, and then you have the epithelium, which is the matrix, and then you have the connective tissue, which is the perimatrix, is what you see in cases of a cholesteatoma. Once again, similar question. We have discussed all this. It keeps on repeating over and over again, but this is November 2021. So we have evolved over time. You get better questions as far as the years go by. So we discussed the most recent, and now we have gone to the previous year questions. Objective tests, straightforward, BERA and OAE and tympanometry. Okay. So 3 important objective tests here. Pure tone audiometry is a subjective test. Let's just A, B, and D is the answer in this case. Right? And one more important here is photoacoustic emission, once again, is a objective test. So remember, among these 4 now, tympanometry, BERA and OAE are objective, pure tone audiometry is a subjective test. Right, which of the following is not seen in superior semicircular canal dehiscence syndrome? Okay, this is November 2019, but this is a hot topic. Okay, this is just waiting to get repeated again sometime or the other, because this is seen as a question that keeps coming in other exams, and definitely this is going to be there in one of the next exams that you are going to see. So when you talk about superior semicircular canal dehiscence, right, so you have 2 windows already, that is oval window and round window. So when there is a superior semicircular canal dehiscence, this becomes a third window. So what happens when there's a third window? What is Tullio phenomenon? Noise induced vertigo. Okay, noise induced vertigo is called as Tullio phenomenon, seen in cases of a third window phenomenon. Let's see, I'm not talking only about superior semicircular canal dehiscence, I'm also talking about a perilymphatic fistula. Okay, so the Tullio phenomenon is seen in cases of a third window. Autophony is seen in cases of third window. Oral fullness, is it seen? Not seen. It can be seen in case of third window. SNHL is not a feature of superior semicircular canal dehiscence. They are called as superconductors, right? They have a very low frequency conductor, or their conduction is much better as far as the dehiscence is concerned, right? So these are the key features here of superior semicircular canal dehiscence. Autophony, vertigo, that is noise induced vertigo, which is also called as Tullio phenomenon. You see a low frequency conductive hearing loss in case of superior semicircular canal dehiscence along with tinnitus. Hyperacusis, oscillopsia, when the patient moves, you see that the surroundings also move. When the patient is hopping around, you can see the surroundings going up and down. So how do you diagnose it? You require a very high resolution temporal bone CT scan, ideally in the range of 0.3 to 0.6 millimeter cuts. You will be able to see the dehiscence of the superior semicircular canal, and then surgery is one of the options, or the only option you can have, where you plug off the third window with a seal. Yes, it can be seen in Meniere's disease. Okay, a patient was operated for safe chronic suppurative otitis media in the right ear, following which he complains of vertigo, tinnitus, and fullness of the ear. You see, surgically operated, so straight away the diagnosis goes in favor of a perilymphatic fistula. This was asked way back in November 2021, right? So the patient who has been operated for safe CSOM, you see the symptoms improve on keeping the right ear up. So there is a sort of a relieving factor. You will not think in terms of a vestibular schwannoma. Labyrinthitis will be there throughout the day, so you will not think in terms of labyrinthitis. Pediatric disease, I don't know why it has come here. So perilymphatic fistula is a straightforward option. Once again, a third window phenomenon, what you see, right? Okay, which of the following method of rehabilitation of hearing should be done in a child with atresia of both the external auditory canal? Can you use a hearing aid? No, there is no external auditory canal. How will you use a hearing aid? Definitely, hearing aid is an option for patients who have moderate to severe degrees of sensory neural hearing loss, unilateral or bilateral. You can use hearing aid. When you talk about middle ear implant, you need the thresholds to be stable. So when the air conduction or the bone conduction thresholds are stable, middle ear implants can be used both for conductive as well as sensory neural hearing loss. So when you talk about bone conduction thresholds, it has to be in the range of 500 to 4000 hertz. And when you talk about when you talk about sensory neural hearing loss, you're looking at air conduction thresholds. It has to be in the range of 500 to 6000 hertz. Okay. So for middle ear implants, these thresholds should be stable enough for you to give a rehabilitation. Now, once again, atresia, how will you do a middle ear implant? Not possible, right? Bone anchored hearing aids, a very, very valid option for atresia of a single or bilateral external auditory canal. Bone anchored hearing implants are placed behind. It's got a implant with an abutment, and over a period of time you can attach the processor. Cochlear implant, where is it preferred? You can have prelingual hearing loss or postlingual deafness. And when you talk about prelingual sensory neural hearing loss, most often when you have bilateral hearing loss, profound sensory neural hearing loss, you will do a cochlear implantation. Postlingual hearing loss also, you can do a cochlear implantation. In patients who are not amenable to hearing aids, you can do a cochlear implantation. In patients who do not prefer any of the above implants, you can do a cochlear implantation, right? Okay, this is straightforward. I'll just go quickly on this. Caloric test. What is the type of nystagmus you would like to expect on cold water irrigation? Very famous mnemonic cows. Cold to the opposite side, warm to the same side. So this is cold water irrigation. So what would be there? To the opposite side, right? So there will be a horizontal or vertical. It stimulates the lateral semicircular canal. So it will be a horizontal nystagmus, right? So horizontal nystagmus. Okay, two options here. So cold water to the opposite side. So horizontal nystagmus to the opposite side. Straightforward answer here. Okay, 2 or 3 more questions to go. So we have a 55-year-old man comes to the hospital with history of trauma to the ear. On examination, there is swelling, tenderness, discoloration of the ear. Which of the following is false? False regarding the given image. See this particular image? What would you do? Let's go one by one options. Okay, let's go to the options one by one. Okay, so what do you have here? Patient has undergone trauma, right? There is injury to the pinna. When there is injury to the pinna, you have the cartilage and the absolutely correct stardust. Resolve spontaneously is the right answer. So when you have injury to the pinna, the cartilage and the perichondrium can separate. When there is separation of the cartilage and the perichondrium, the blood supply to the cartilage goes away. There is a chance of secondary infection because there is no blood supply. So all cases should be given prophylactic antibiotics, right? Because there is a chance of developing perichondritis. May lead to a pugilistic ear. Absolutely correct. Why? When there is no blood supply to the cartilage, what is going to happen? It's going to crumple down and eventually resorb, right? So it can give rise to a pugilistic ear. Third answer is straightforward. They've spoken about the pathogenesis itself caused by accumulation of blood in the pericardial space. So these 3 options are correct. Resolve spontaneously is wrong. Absolutely correct stardust. Few points to remember. I am not going to elaborate on each one of these. Straightforward. You have a image like this when there is trauma, blood or serous. When you talk about serous fluid, it is seroma of the pinna. When you talk about blood, it is hematoma oris, right? Most often it happens due to trauma in seroma of the pinna. Sometimes it can be spontaneous. Both are painless. When you have an abscess, it can be painful. When there is perichondritis, it can be painful. If it is prolonged, it can lead to a cauliflower ear abnormality. Why? We have already seen. What do? You do a window procedure. Okay, you can create a window in the cartilage here. Okay, so you can do it from the front or the lateral aspect, or you can do it from the medial aspect. Create a window, drain out all the serous fluid, and then put a tight pressure bandage, it usually resolves. Aspiration is never an option. Remember, if aspiration is given as an option and a window procedure is given as an option, always choose window procedure. Aspiration can lead to recurrence of seroma or hematoma oris. Complications, as mentioned, it is perichondritis. So this is how perichondritis would look like. You saw this image and you look at this image, right? You see the difference? Inflamed. Common causative organism is Pseudomonas aeruginosa. Common predisposing factor is diabetes mellitus, and pain and extreme redness will be present in cases of perichondritis. Signs of inflammation will be present. There will be fever in cases of perichondritis, and you need to treat the patient with antibiotics and analgesics, right? So what you see here is a patient who had diabetes, who underwent a surgery. Following surgery, she came back with this perichondrial inflammation, and we had to do a window procedure and drain out the abscess. This patient underwent a surgery for external auditory canal malignancy, and following that he received radiation. You can see radiation induced perichondritis in this patient. Extremely painful conditions, very, very difficult to manage. They will require intravenous antibiotics. And when you talk about Pseudomonas aeruginosa, this can also be given. You see that previous MCQ that you saw that the 4 options, you saw that all should receive prophylactic antibiotics, right? Now, given a scenario of perichondritis, what are the antibiotics you would prefer? They can give you anti-pseudomonal antibiotic options along with the non-anti-pseudomonal antibiotic options. So you should be able to differentiate between those as well. Okay, straightforward here once again. Lasting few seconds, we have discussed this in detail, right? Associated with change in head position. Yeah, positional change always goes in favor of a BPPV. Correction by Epley's maneuver is always in BPPV. So when do you do Epley's maneuver or a Simon's maneuver? That is in posterior semicircular canal BPPV, right? When do you do a log roll maneuver? Whenever you have a lateral semicircular canal BPPV, you do a log roll maneuver as treatment. Let's look at the options. What is the diagnostic test used to diagnose this condition? Okay, so you have BPPV, rightly mentioned stardust. It is Dix-Hallpike test. Okay, so you do a Dix-Hallpike test in the same sitting. You can do the particular maneuver, that is Epley's Simon's in case of posterior semicircular canal BPPV, and log roll maneuver in case of lateral semicircular canal BPPV. Remember, Dix-Hallpike test you can always use to find out lateral semicircular canal BPPV as well as posterior semicircular canal BPPV. What about head impulse test? This tests the vestibulo-ocular reflex. Okay, sudden jerks, right? Sudden head movement. You ask the patient to focus on a particular point. Okay, and you give sudden jerks of it and ask the patient to keep focusing on that point. So now let's go back to my right side, which is abnormal. Right side is hypoactive. What happens when there is a sudden jerk? The patient sees on that side, and then there's a corrective maneuver from the opposite side, which is normal. That is known as a corrective saccade. So the corrective saccade is characteristic for peripheral vestibular disorders. So when you talk about peripheral vestibular disorders, you have all the various disorders. You talk about Meniere's disease, so on and so forth. Let's not go into the details of all. Wherever there's a hypoactive labyrinth on the affected side, there will be a corrective saccade to the opposite side in head impulse test. Wherever there is an irritative lesion on one side, there will be a corrective, or the saccade will be towards the same side. Okay, but more often than not, it is used for hypoactive labyrinths. Remember, the corrective saccade is to the opposite side. Caloric test, already mentioned, hypoactive, hyperactive. You do that on a butterfly chart. You will be able to find out which part is hypoactive or hyperactive. Electronystymography, once again done to check the vestibulo-ocular reflex and also for supranuclear oculomotor testing. This is a 1 hour topic itself. Supranuclear oculomotor system is a 1 hour topic itself. So it can test the vestibulo-ocular reflex along with the supranuclear oculomotor system, that is electronystagmography. Now there is a variation to that, that is the video nystagmography, which has come into foray. So this was asked way back in 2020 when VNG was still in the initial stages. Okay, this is what we've discussed. Right. Simple, straightforward, 6-year-old boy, recurrent URTI, pure growth. This I added, although it has to come in adenoids because there was a hint of tympanogram here. That is why I put it here. So high arched palate, impaired hearing. Tympanogram shows a flat configuration. So a B-type curve. Where do you see a B-type curve? If there is a perforation of the tympanic membrane, or if there is a fluid in the middle ear. Okay. So non-compliant tympanic membrane with change in pressure is a B-type curve, right? A-type curve is normal. You have AS-type curve, that is reduced compliance. This is a normal curve. You see the compliance on the y-axis. You see the pressure change on the x-axis. Okay, so this is pressure. This is compliance of the middle ear. So this is normal. If there's reduced compliance, you're thinking that is an AS type of curve you see in cases of stapes fixation or ossicular fixation. Then you have increased compliance, that is AD type of curve at ambient pressure, that is seen in cases of ossicular discontinuity. And then you have a C type of curve, that is at negative pressure, you have a peak, that is usually seen in cases of a retracted tympanic membrane. Yes, Stardust, adenoidectomy with grommet insertion is the right answer here, because flat curve means fluid in the middle ear. You have to drain the fluid. So you do a myringotomy along with the grommet insertion. When you do a myringotomy with the grommet insertion, it should be in the antero-inferior quadrant. In acute suppurative otitis media, the incision is a curvy linear incision from the postero-inferior to the antero-inferior quadrants. So this is what it looked like. You have adenoid facies. You can see adenoids here, enlarged adenoids. You can see a conductive hearing loss on both the sides along with a B-type curve on the left side. So diagnostic of adenoid enlargement or adenoid hypertrophy. So recent question that has been asked, identify the joint, right? So what is the answer here? Saddle, ball and socket, fibrous, gliding. Which one? Give away the answer. Okay, so let me give away the answer. So since this question has been asked, there is a chance that there can be other joints in the head and neck that can be asked, right? So when you talk of ball and socket joints in the head and neck, it is incudostapedial joint and cricoarytenoid joint. So these two joints are the ball and socket joints in the head and neck. When we talk about hinge joints, it is the temporomandibular joint and the cricothyroid joint. When we talk about saddle, it is incudomalleal joint. Okay, so Rahul, remember, incudomalleal joint is saddle, incudostapedial joint is ball and socket. So what was the question here? You see the circular mark there. Yes. So both of you are correct. Rahul and Stardust, both of you are correct. Incudomalleal joint is a saddle type of joint. Incudostapedial joint is a ball and socket type of joint. And cricoarytenoid joint, once again, is a ball. So you remember this 2 to 1. If a question is asked based on the type of joints, you will be able to go through easily. Okay, now let's show you a few images. Okay. So coming to the last part here, you see this? This patient is undergoing a lateral temporal bone resection for a malignancy, okay, of the temporal bone. Following the surgery, this patient is going to say, I don't have any sensation of the pinna, right? So Stardust TM joint is a condylar joint. Yes, it is a condylar joint. Yeah, it is a hinge type of condylar joint. Yeah, okay. Okay, so what do you have here? This patient says there is tingling and numbness of the pinna, and you have this nerve which usually supplies the pinna. So what is this nerve here in this image? What is the nerve? Should I give away the answer? It is? No, this is anterior. This is along the sternocleidomastoid. Okay. See the pinna here? Along the sternocleidomastoid, what nerve do you get? You get the greater auricular nerve. Okay, so that nerve is the greater auricular nerve which supplies the pinna. Okay, right. Let's come to the next image. What do you see here? It should have been very close to the mastoid tip or the sternocleidomastoid. This patient presents with persistent discharge from the post-oral area, okay, very close to the sternocleidomastoid and the mastoid tip. And along with that, if you look at the external auditory canal, there is one more opening. Okay, this is the first branchial arch anomaly. This is not a Bisolt's abscess. Okay, what I told you was there is an opening in the external auditory canal. At the same time, there is an opening lower down in the neck. This is a first branchial cleft anomaly, and this is known as a call-oral fistula. Okay, this is a call-oral fistula, one of the important external auditory canal disorders. Okay, this is commonly asked. Okay, in other exams it has been asked, but not so commonly asked in INI-CET. A 50-year-old woman presents to you with excruciating pain, worse in the night, copious purulent ear discharge. On examination, there is granulation tissue present in the external auditory canal, and sometimes they may present to you with facial nerve paralysis or lower cranial nerve paralysis. So what would be the diagnosis if you look at this picture? Malignant otitis externa, right? Right. So malignant otitis externa is the diagnosis here. So when we talk about malignant otitis externa, the earliest investigation which will help us diagnose is a technetium 99M scan, right? What will tell us about the extent of disease? It is CT and MRI. What will help us with the prognosis? It is gallium. So you can see the different investigations that are mentioned. Okay, earliest to diagnose technetium 99M, extent of disease CT and MRI, prognosis gallium. Always go for a hybrid imaging modality. So you can also use few blood investigations as far as malignant otitis externa is concerned. You have CRP and ESR, which is done pre-treatment, post-treatment. It will help us in guiding with the prognosis. Remember, it happens most commonly in diabetics or in immunosuppressed individuals. Okay, this is a 25-year-old man presenting with what is IOC? I did not get the question. What is IOC? Did I mention IOC anywhere? Stardust, can you elaborate on that? Okay. Okay, sorry about that. Okay, investigation of choice is always CT and MRI. Okay, so investigation of choice is CT and MRI as far as malignant otitis externa is concerned. Earliest to diagnose would be a technetium 99M, and prognosis would be gallium scan. Right, let's come to this image. So what do you see in this image? This is a 25-year-old man presenting to you with lesions. You can visualize this, excruciating pain, and along with that, this patient has got a lower motor neuron type of facial paralysis. What would be your diagnosis? Excruciating pain, lesions on the pinna, lower motor neuron type of facial paralysis. He had fever initially. Yes. Vesicles on the external ear. Diagnosis of. What is the diagnosis? Herpes. Yes. So, herpes zoster oticus. Ramsay Hunt syndrome. Diagnosis is purely clinical. When you look at, it's basically because of reactivation of the varicella zoster virus in the geniculate ganglion. And when you look at the treatment, you can treat them with acyclovir and steroids or valacyclovir and steroids. And this has to be done for a period of 2 weeks. And you can see the patient coming back to absolute normalcy after you treat these patients. Remember, this is a viral infection, so sometimes these patients can present to you with sensory neural hearing loss as well. What about this one? This patient says that it has been present since birth. Occasionally, there is some pus discharge coming out of this particular opening. What would be the diagnosis? Straightforward, right? So when you get images like this, it becomes very easy. Okay, straightforward. There are lots of places in ENT where you can give a spot diagnosis, and this is one of them. Congenital anomaly of the first and second arch. Remember, you need to know everything about this. They can put an image like this, and then they can give you 4 options as to which of the following is false. So remember, preauricular sinus is congenital. It is a abnormality of the first and the second branchial arch. It can get infected. So what would be the treatment? If it is infected or if there is an abscess formation, like in this case, you will have to do an incision and drainage. You can excise the tract only after the inflammation around has healed. So you're looking at somewhere in the range of 4 to 6 weeks, ideally 6 weeks is when you will excise the tract. Remember, when you're excising the tract, it will have patterns, right? It is not a single tract like this. There will be patterns. So if there is an infected tract, never operate on this patient. You need to inject dye into these tracts, identify the tract and excise the tract in toto. Okay, so this was the last image. So with this, I have come to the end of discussion of otology INI-CET PYQs. Hope this has been an informative session for all those who are present and have seen this session.